We're going to get started here. You'll probably be breaking my ribs right now. So we'll start out with roll call, please.
Certainly. Jack Early.
Enjoying lunch.
That counts as a present. Lou Jones.
Yes, sir.
Patrice Delameter has an excused absence. She had to work today. Fulton County, we had Yvonne Hart here, had to leave to go back to a meeting. She's our new member replacement for Bonnie Lumen. And she had to leave to go to an executive meeting back at the hospital. Jack Farquhar.
Here.
Howard Heim is excused. He had to work today. Jill Dunham.
Here.
Chris Perez is here. Welcome. Good to have you. Hamilton County, Cindy Dunham is excused. Joyce Belidi is excused. In case some of you didn't hear, we took Joyce's father to the hospital last night, a little bit after 11. He was admitted to the hospital. He's in Nathan LaTour. His condition is guarded at the present time. And Joyce and her sister and mother spent the whole night at the hospital, so she is resting right now. She is resting right now. Phil Belidi is present. Gary Wicks.
Here.
Tom Pasquarelli.
Would like to be excused for work.
He would? Excused from work or excused because of work?
For work.
Okay.
There is no excuse for time.
Mickey Swartz.
Here.
Trish Payne.
Here.
Jared Gilson is working, I presume.
You could presume that.
Okay. Otsego County, Sid Chase.
Here.
Brian Knapp. I presume he's working. He normally sends me an email, but sometimes folks send me an email on Thursday morning and I don't get to see it until Thursday night. Dr. Markowitz.
Here.
Dana Wygand.
Working.
Up in the air, huh? Okay. Rich Kirschman.
Here.
Andy Cuccinello.
Here.
Ed Brand. And William Beavers.
Here.
Mark Zeke is on the road somewhere and has an excused absence. And Dr. Leinhardt just came in. And so we have a quorum.
Okay, very good. Okay, welcome everyone. We'll start out with minutes from last month's meeting. Everyone got a copy of the minutes? Need a motion to approve?
Someone make the motion.
Motion made.
Motion made. Second. All those in favor signify by saying aye.
Aye.
Any approved? Any abstain? Okay. We have some guests.
We have some guests. We have a bunch of guests today. The state contingent is led off by, pause here for a drum roll, Lee Burns.
I thought you were going to say Joe Farrell.
Lee, it's nice to have you here.
Thank you.
We have Mary Ramo and Joe Farrell. I didn't mean to make that sound like an afterthought, you know.
That's perfectly okay.
Okay.
You should hear how Lee usually refers to us.
We have Howard Youth here today and Deb Cuss from the paramedic programs at SUNY Cobblesville and HVCC respectively too, of course. Mark Hitchcock is here. Tony Aggressive from the Amsterdam Fire Department. Beth McGowan from CMT. Karen Cuccinello from Summit. Did you know there was a town named Summit in our region? Okay, yes there is. Yes there is. Way up in the air. Higher even than southern Hamilton County. Higher in sea level. Okay, welcome one and all.
Okay, moving on to our correspondence. Everyone get a copy of correspondence? I don't really have a report other than thanks for all the well-wishers. It's good to be back. Feel funny when you miss a meeting and you come back a month late. We'll move on to the Secretary's report.
Okay. Not too much to report this time. I believe the annual budget template and training plan was sent electronically to Lisa DeLong at the DOH on September 24th. On September 27th, we received word from Mike Taylor at the Department of Health that the EMS Bureau is making arrangements to resume paper PCR screening. Paper PCR screening has not been done since January. We have 9 months worth of paper PCRs all cataloged and ready to send down to wherever we're going to send them, but we haven't gotten the word yet. On September 28th and 29th, CLI course number 113050 was conducted and successfully concluded at SUNY Cobblesville. 12 students attended and completed. More about that in just a minute. On October 7th, we received word from Lee Burns that SAMSCO had approved the policy of CMAQ that all ALS, that is paramedic and critical care agencies in the state, must have controlled substances licenses by May the 1st of 2015. This information was forwarded to all our council and REMAC members as soon as it was received. As of October 10th, all agencies using the EPR system, EPCR system, had been advised of their state bridge accounts, allowing them to access the bridge to review their submissions, and also allowing them to create and submit monthly data quality reports. And we don't have any notice of enforcement actions this month. And that serves my report.
Very good.
Does that mean that people have not been misbehaving, or just that they haven't been caught yet?
Haven't been caught.
Okay.
Okay, thank you. Treasurer's reports.
We have a printed report of the cash flow and balance sheet here available for everybody to take a copy of. In addition, Lou and Sid received detailed cash flow balance sheets and register reports, plus copies of our canceled checks as per the review arrangements agreed on to meet audit standards. Their report is?
We found everything to be intact and up to date.
And our policy is that if a member of the committee is not present, that material is kept for them for the next meeting where they are present. So everybody has a chance to review all of the financial information and sign off on it. Okay, kind of a lengthy paragraph here on the state making payments to us. Bottom line on the whole thing, on September 10th, Lisa DeLong advised all program agencies she was seeking to determine when the encumbered funds would be released. She noted they were supposed to have been released the previous week. On October 1st, we received a check in the amount of $99,2469. This represents the past due payment from March 31st of $98,8620 plus a DOH late payment fee of $38.49. On October 11th, we received a check for $35,761.34. This is payment of our council voucher for June the 30th and our program voucher for June the 30th, plus a late payment fee of $59.50. The state now, since March 31st, has given us a total of late payments of $97.99. I present that without really any comment, but with a sense of wonderment about the whole thing. On October 2nd, we forwarded to Lisa DeLong the council contract deliverables for the period from July 1 through September 30th, together with an expense voucher for $1,300.71. Typically, one of the quarters is a very low expenditure, and then the others pick it up. On the same date, we also forwarded the program deliverables and a voucher for $27,808.95 for the same time period. That won't really be due. The 30 days on that will be due early in November.
Yeah.
And that is my report, sir.
Okay. Thank you very much. Need a motion on the treasurer's report.
Make a motion. Second.
Been made by...
Thank you.
Thank you.
Okay.
Motion's been made and seconded to accept the treasurer's report as presented. All those in favor signify by saying aye. Aye. Any opposed or abstained?
I will abstain as a state member.
Okay, committee reports. Anything on program agency?
No, nothing.
We want to briefly touch on field training, cardiac teaching day.
Yes. Our training committee meeting was this morning at 11ish, and Joyce, of course, was not able to be present, and regret that she wasn't. And she asked me to bring up just 2 points which we discussed. We discussed the CLI class that was concluded. We talked about the cardiac teaching day. Strangely enough, we have not received any registrations at all for the cardiac teaching day to date. Now, the cutoff date, which we put in the flyer for it, is October the 28th, I believe, what we said. But so far, nobody has signed up. It has been quite widely publicized. We're hopeful that we will not have to cancel it, but obviously if we don't receive any registrations, because we don't accept any at the door, we're going to have to cancel. And then Lee led a discussion on the Vital Signs Conference and, attendance of training conferences in general. So we had a good little meeting. Anybody have anything else to add to what we discussed this morning?
Transportation standards?
Transportation standards. As of this writing, I roll this forward every month. Nothing further has been heard from Sharon Springs, Hancock, or Sydney relative to their earlier inquiries about CON processes. On May the 13th of this year, we received paperwork from Racket Lake requesting a transfer of operating authority. It's still going, it's still a work in progress. On October 4th, I received a revised application from Racket Lake containing revisions that Dana Jones of DOH has requested, and it was forwarded to him for review and comment on October 7th. I have not, as of right now, heard back from Dana, so the next step for us is to declare the application complete, and I really don't want to do that until Dana has reviewed it, because if we declare it complete, but he says it's not complete, then it's not complete. Simple as that. So we're hanging fire, waiting for Dana Jones to get back to me as to the completeness of the application. When that occurs, we can schedule the vote for it, and I think there are no extra steps required. We can just go ahead and have the roll call vote at the next meeting as soon as it's declared complete. That's all I have for transportation standards, sir.
If I could ask from the state, have you guys heard anything more from Hancock or Sydney?
Everything remains stagnant, as it was the last 18 months.
Because I know in local paper there was an article regarding town of Sydney, and one of the things that the supervisor had made a comment on is their application for ambulance service, and trying to get some of the other neighboring towns interested in forming this ambulance service, and that's, I haven't heard anything more. Yes.
They received a grant to do a feasibility study, and as far as I know, nothing has been come forth from that grant.
This is Sydney we're talking about.
Nothing on state council?
No?
I have a state council report for Mark,
Oh, okay.
and we have a person to tell us all about state council sitting next to me.
Okay.
Actually, this works out well. One of the reasons that I darken your door is to kind of give you the thumbnail sketch of a couple of different things that are going on that you need to hear about because it affects you. So the first, have you heard anything about the possibility of changing Article 30 or reforming it? Just to give you kind of the 10-second Cliff Note history, the governor has included the entirety of Article 30 in the last two budget bills to make sweeping reforms. And because of various places I've been and people I've met, I'm a legislative moron, frankly. I don't get the process particularly, and I try to ignore it as much as I can because it's scary. The budget, in the first year, the Article 30 was, the Assembly made a pass at a version of Article 30 in their budget proposal, and the Senate just took it out and it died. Much to my stun and amazement the second time, and I now have, a couple of helmets with which to wear when I'm under my desk diving for protection. The second year, before it showed up in the budget bill, my office was contacted and asked what we would suggest in a newer version in the budget bill. And after we stopped crying and shaking, we were very specific about a couple things. We wanted to change the language of 3,000 to enable what was commonly referred to as community paramedicine, but now is being called mobile integrated healthcare. We really specifically looked at the education sections in the 3050s to try and change the way that Article 30 articulates EMS education to a more of a scope of practice model, which would lend itself better to the current education that's going on in the state and the national education standard. And we wanted, quite frankly, to get rid of, make forgone forever, the 5-year CME program. There are 3 people left in the 5-year CME program in the state. It's panned pretty much. There's one on Long Island and the rest are in your region. It's very, as you know, because some of you have tried to do it, it's difficult and it just never took off. But the bigger piece of it is that for even longer, the 3-year program has been in pilot and remains in pilot. And our other thing to that was we wanted it to be like permanent, so that it would no longer be in pilot, it would be permanently included in statute. And then we thought that 6 councils were too few and said, well, what about 10? And so there were a couple of things in there. And it was, I had the opportunity to meet with a senior state senator on this and other things. And he basically, he was very charming. He said, you know, you're a very nice young woman. And I thought, wow, he thinks I'm young and nice. Who knew? But his comment to me was that the EMS is, from a budget perspective, there's no net gain by having EMS in the budget. It's flat. And I walked away thinking, oh my God, we're going to have to do this another way if we have to do this. And I could have burst into tears till I thought about it and realized, no, you know, maybe he does know that you can't take any more money out of the EMS budget. So I guess being a non-budget issue is good. And I thought, well, okay, down 2. And if they're not going to approve it in the budget, maybe all this will stop and I can get fewer gray hairs. So then shortly thereafter, the governor's office reached out to the health department and said, this is still in the governor's agenda. It's a matter of efficiency. And we want to meet with the stakeholders. And so this was my contribution to all of this fun. They said identify stakeholders. And what I did in consultation with politically correct people that I am not, is we identified organizations that are stakeholders in EMS. So as an example, Onion, the volunteer ambulance, all of the fire, you know, the chiefs, FASNY, districts, the union, the ASEP, surgeons, the ENA, and the New York State nurses, NISNA, trauma people, so we, on and on. So we identified everybody who didn't stand still long enough from an organizational perspective. My thinking with that was simply that the health department and the governor's office should not say, well, today, Dr. So-and-so is going to be, you know, ASEP's representative. So what they wrote to the organizations, and the organizations identified their representative to this meeting. And the first meeting was held in the Capitol, and it was very lively. I walked out of there thinking I could cry. I'm just, you know, I'm never going to live through this. It's utterly painful. And it was somewhat embarrassing as an EMS provider, that meeting. And so subsequently, basically the meeting was a group of people standing there saying, nothing's broken, you can't fix it. And I was horrified because, with all due respect, Article 30 really is, unfortunately, outdated. It doesn't reflect the EMS community as it is today. It doesn't help you do your job. It doesn't help you treat patients. It doesn't help you teach EMS providers. It doesn't help the public. So the question really is how to make it better. And the governor's office didn't forget about it after that and held 3 more meetings. So there was 1 in July and 2 in August. Same groups, some same people. And they went through the law basically using the budget language framework. So the first meeting we talked about the streamlining of the state bodies. There are 4 councils at the state level. And my thinking was one huge council is probably not going to work. And the New York City REMSCO actually wrote the governor's office a position statement, and it was excellent. I would even tell Nancy Benedetto that. And what they said was there should be 2 statutory advisory groups to the commissioner. Essentially a systems committee, which is very similar to the current SEMSCO, and a physicians committee, which would include representation from the strength of it would be the emergency physicians, but it would also include trauma surgeons, pediatric surgeons, cardiologists, and make a well-rounded physicians committee that could address EMS and trauma issues in New York State. Because you wonder about trauma. We also deal with trauma lots. That'll be on later in the state report. So I thought that was kind of a brilliant idea. And then at this first meeting, we brought flow charts, and everyone said, no, there should be 1 advisory group to the commissioner with 2 statutory subcommittees, 1 docs, 1 systems. So that was the first meeting. The second meeting discussed the reforming how the regional councils are set up. Now in the budget bill, everybody kind of panicked about how the regional councils were articulated, but really from a statutory authority there was no change. What they really need to do, we have 18 regional councils in the state. The question is, at this point in our evolution, are 18 regional councils necessary? Could we do a better job with fewer regional councils? And so they talked about it. My other contribution was the governor's lawyer person council said, take a map of New York State and split it up. And think about the governor's economic council. So I web surfed and looked at the governor's economic councils and thought, that isn't going to work. That's really freaky. And it doesn't lend itself to EMS. So every now and then I have a cogent moment, and if you've ever seen the map, and I can send it if you haven't, but they said make 10 regional councils as a matter of a starting point for conversation. So a matter of discussion, not fixed in stone. And what I did is I looked at EMS agencies, protocols, medical control, patient referral patterns, training, everything I could possibly think of that would have trauma centers, regional resource centers, hospitals coming, hospitals going. There are no hospitals coming, they're mostly going. And everything. And I took my felt tip pen and then I PDF'd it, and it was a starting point for a conversation. And everybody looked and thought, wow, wow. What it did is it grew the regions a bit because present company excluded, quite frankly, mostly because the competition and killing of each other doesn't affect you all as much as many of the other regional councils. The reality is making the councils bigger, or geography, making the geography bigger takes what is a closed group of people and grows it so that there are more objective minds at work. And all I could think of was my new best friend Mark Ambrose in the city of Utica. That council, there was nothing Utica, good, bad, or indifferent, nothing Utica could do because everybody lives there and they're all fighting with each other and they all grew up together and they're all friends and they all hate each other and all of that. And you're like that. You know, I look around the room and recognize 99% of you because you're part of the fabric of the community. So that was sort of, it was to grow the regions to make them a little bit more objective. Anyway, again, nothing's been cast in stone. And when the first bill came out, someone said, well, what do you think about regions? And I said, honestly, my thinking was the regions should develop the regions. But I'm not sure that we could pull that off really well. But what it does need to do is represent the diversity of the geography. And the other piece to that was We know that the metropolitan and suburban New York is very well represented by specific regions. It's not a slam. New York City, Remsco does an absolutely excellent job in New York City. But however we split up the regions, we also have to have specifically rural regions so that it balances out in terms of representation. And our current structure does not do that. And there's some, besides your region, which is primarily rural except for the metropolis of Amsterdam, the southern tier is very, very rural, and they have a very, very strong rural bend to them. So I think that was the other piece of it, is that I looked at splitting up the state so that there was a strong representation of rural New York. So that was the next series. Then we moved on to the other councils. We have an EMS for children and a trauma council, and what to do with them. And we have regional trauma advisory committees. This doesn't really affect you because your RTAC is pretty isolated from you and not very active. And then the last part of the meeting, besides talking about the CME programs, and everybody was, it is clear that the CME program is here to stay. It should be. We need to make it better and stronger, but we need to make it permanent. And no one really cares about the 5-year program except for probably the 3 people in it. And then there was the municipal CON. And there's still a lot of work to be had about that. There was very, very, I was impressed. There was unbelievably intellectual and civil conversation about it. And there was nothing in the end was kind of brought to any sort of consensus. And at the risk of getting killed early on by my friends in Onion, I said, my feeling after living through this for years is get rid of the 2-year thing. It's not fair to the regional councils. It's not fair to the applicant. And it was death-defying. So I don't know what the end result is going to be, but the reality at this point is when a municipality decides it's going to be an ambulance service or an ALS first response service, it puts money and resources into it and operates for 2 years. It should not, at that point, there's nothing the regional council can fairly do to end it. And no regional council has been able to do that. But more importantly, when the municipality itself, disregarding the EMS players or the unions or whatever, when a municipality comes to the conclusion, they're thinking of here and now. We need ambulance or ALS first response service right now. They don't care about 2 years down the road. Doesn't matter to them. And so they're going to do it regardless of whether they have to do the 2-year thing or not. And having spoken to many town fathers, that's a reality. But that is not, I don't think that is where it's going to go. So that's kind of the Cliff Note version of Article 30. My request to you is just, it's a couple-fold. One is kind of keep it on your radar scope. Don't think that someone else is listening. Kind of pay attention, because I think that it's important. I think in the end, we need a good statute. The current statute was great in 1990. Most of you were around then. But it's now 2013. This governor is going to be around for a while, and for some reason, he hasn't let this go. Unfortunately, the attorney that we've been working with in the governor's office of counsel has taken another job, which, I mean, she's awesome. She's going to be working for the health department, so that's okay. However, so there's a new attorney who's very, very smart, and we are on her top 3 list. EMS is on her top 3 list. So this is certainly not the last time you have heard about this. So I know a couple of you have kind of taken some written positions that I've read and responded to. But what I would say to you is, don't sit here and say Article 30 doesn't need to be changed. Sit here and say, let's change it so that it's good for us and our patients. It took to the 3rd actually the total of 4 meetings. It took to the last meeting for one of the stakeholders to utter the term patient. It was one of the trauma surgeons. So my concern is that it's not all about me, it's not all about you, it's really about the patients. And I think that it needs to be patient and provider centric, not patient and organization centric or patient and municipality centric. It really, really, really has to grow. It's time. So now I'm off my soapbox. So a couple of other quick things also affecting you. There is a new concept in New York State called the freestanding emergency department. We saw it as a result of Hurricane Sandy in New York City. Right now there are 3 operating in New York City. They're basically, the feds, CMS calls them off-campus emergency departments, or free something or other. The feds call them Fed. But the difference between one of these URGE centers where you can go running in there and say you don't feel well or you need stitches and a freestanding ED for the MS community is the ambulance can transport to a freestanding ED because it falls under the 405 code for hospitals. Right now, the hospital, it's called the Public Health and Facility Planning Committee, FIPIC, is considering an application outside of New York City for Ellis at Clifton Park, Lake Placid, and one out in Lockport outside of Rochester. Now for your communities, they're terrific. For the ambulance services going in, good. But the problem is that I've been all over them as this progresses to make sure that the presence of a freestanding emergency department does not negatively impact the EMS community, because what I want these freestanding EDs to do essentially is have contracts or agreements for transports out, because I think if I put a freestanding ED in Speculator, it's terrific going in, but say you have a sick person going out, not so good. So it becomes interfacility transfer. So it's worked out really well in New York City because we make them get contracts. It's going to be more interesting outside of the city. Also, so keep your eyes open for that. Trauma verification. The staff, the State Trauma Advisory Committee and the Commissioner decided that rather than New York State freely designating trauma centers based on an outdated section of regulation, they would adopt the American College of Surgeons Committee on Trauma Verification process. It's very exciting, actually. I thought for sure if Article 30 didn't kill me, the trauma surgeons were going to slice and dice me. So basically there are 4 levels of trauma centers in the ACS group. So level 1 is what you're used to, Albany Med, upstate. Level 2 is really more regional, so like St. E's and Utica will probably be a level, actually it'll probably be a level 3, but it could be a level 2. Then there's level 3, so like Plattsburgh is likely to be a level 3, and then there's level 4s. And a level 4 is, the college used to call them field trauma treatment centers or something, field something or other. And basically, the commissioner said they need to do this and they need to do this by this date. They have to have committed to it by May of 2013, and all of them have to be verified by May of 2015, or have their visits or whatever. So the hospitals, interestingly, have been unbelievably accepting of this, and have all of our current trauma centers have scheduled visits from the college for consultative visits. We have gotten an amazing, interesting number of hospitals who have never been in the system but want to be in the system, and a couple of really rural hospitals who are looking at the level 4. So that will be good for the EMS system. So I'm not sure what they're doing locally here, but like Clifton Fine up in Star Lake wants to be a level 4. Elizabethtown a level 4. So that's actually, it really basically a level 4 is trauma. The healthcare providers in the hospital are trained in trauma resuscitation, and they have to have agreements to get patients out. So the strength of it is that they have to work with the EMS system coming in and going. The other piece is, and why it's important to you, is that as hospitals move towards verification, they need to get along well and work with their EMS system. And that's been very interesting, because I went on a consultative visit, and the college folks kept asking, this is a university hospital, kept asking about what they did with their EMS system, and the ED director, who's not really engaged in working with EMS providers, really had no answers. And since I was a paramedic in the region, the trauma service kept looking at me saying, yeah, but Lee, don't you go to the trauma symposium? I said, well, yeah, they do this, 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 and this, and this, 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 and this. And the ED director walked out with me and said, wow, I should have probably had Dr. So-and-so with me. I'm like, yeah, kind of. So all these hospitals have some work to do, but again, it does affect you. The Narcan naloxone pilot program was approved by the CMAC and the Sensco, and I've sent everything to the commissioner. He's aware of it and very interested in it. And interestingly, when it's for BLS providers, aerosolized Narcan, the public health, the AIDS Institute is looking at funding the startup programs for BLS Narcan. So we're waiting to see. We've given them some costs, so that would be exciting. But what we figure is that there's a specific kit which would include 2 pre-filled naloxone 2 milligrams in 2 mLs, and then 2 mucosal atomizer devices, and the totals per kit is probably about $40. But the public health people are looking at purchasing it. Who knew? And then the elephant in the room is the controlled substances for ALS providers. And I have worked with the CMAC and folks to put together the policy statement. Mark Zeke did really, actually probably you did most of it. These people here did a monumental job doing an impact study, and it was interesting. Even people who were upset about it really did recognize it's a standard of care. And it was a lot of soul searching for the representatives on the SEMSCO. And it's not a dollar issue, actually. Controlled substances are cheap. But it is an administrative issue. It is an inventory issue. It is a security issue. But everybody's like, well, we're going to be BLS if we have to do this. You know what? Honestly, at this point, I fear that if you have a small rescue squad that has 1 or 2 ALS providers, at the risk of getting killed, I really think maybe they need to take a step back, take a deep breath, become better at BLS, and if it works for them, make another approach at being ALS. Because honestly, controlled substances are a standard of care, but it's symptomatic of the reality that if they're not doing this, what else are they not doing? And it's painful because I'm very conflicted. Is some ALS better than none? And I have to tell you, I'm not sure it is. I think there are areas of this state that would benefit from stronger BLS and not having weak ALS. So that's my other soapbox. But you guys have the first viewing of the policy statement. It should go up online in the next couple of days, and I'll get it out electronically to all that Phil can forward and post to. So, and the last, just a quick thing, we've gotten a lot of questions about whether EMS providers have to adhere to the flu mask vaccine regulations. And the answer to that, unfortunately or fortunately, is no. Article 30 is not included in that. While I would say to you, because I have to, getting the flu shot is worthwhile and a good thing, and it is. No sarcasm intended. nonetheless, you are not beholden to that section of the regulations.
Mark's notes indicate otherwise.
The students.
So do they should.
It says that it does, however, apply to EMS students working on their ride time.
If they're assigned to hospitals. Yeah, unless employed by a hospital. Actually, even if they're employed by a hospital, if they're in the hospital, they have to, but on the ambulances, they don't.
Can we get that in writing?
It is in writing, actually, on the website. In going back through Mark's report, we're also, as you know, Mike Taylor's back with us again, and he is assigned pretty much to the data, and so he's visiting with all the program agencies. He's visited with you, hasn't he?
Yeah, he was here last month.
To get
Not here, but in the region.
yeah, he's starting with the program agencies to to kind of renew getting people up and running on the state bridge, and then we're going to start reaching back towards the services who we know are approved electronic submitters, and we're going to start asking why they're not submitting, and we're going to start hounding the crap out of them, and then we're going to start nagging on the non-electronic submitters. So we have a whole plan. Yes, there's no money for that. What else?
Two things that, a couple other things. Just FYI, Hudson Valley and Westchester accepted the collaborative protocols, so we now run from Yonkers to Canada on one set of protocols. Next year's Vital Signs Conference will be in Rochester. Please check your pediatric equipment list policies. It's time for the resurvey on the pediatric equipment lists. That will not be an all-inclusive, all-agency survey. It will be a selected agency survey to see how close you are in compliance with the something or other pediatric equipment.
American,
Thank you.
something of pediatrics.
CMAC approved needle chest decompression added to the AEMT curriculum. Norepinephrine was added to the formulary, and rocuronium was added to the state formulary.
Just a quick word about the budget, the money thing, because it's salient to what you do. And I explained this to the SEMSCO also. Our annual, meaning all of us, you included, governor's budget allots $19.7 million, and it's been that way now for years, probably 8. And over the last couple of years, and I can't explain this because I don't know, I just don't understand it. But when it goes from the governor's allocation to actual dollars, it goes from 19.7, it went to 18.3. And I don't really know where the $1.4 million went. I think it's hard to lose $1.4 million, and if you're gonna, I'd like you to lose it towards me, but they didn't. So for the last 3 years, the EMS account has started with $18.3 million. In the 2012-13, I guess 13-14 were it, rather than 18.3, we were allotted 15.6. And that really scared me. And so I found out why. It's totally different than the 18.3 transfer. I think that was just skimmed off the top. I don't know. But what the Division of Budget did is, and this is the part that really is frightening. It's so, as Phil has articulated to you, it is so difficult to get vouchers paid and contracts executed and people reimbursed, that as money, basically what the DOB did is they looked at actual expenses and they said, well, in the 12-13 budget year, EMS only spent 15.6, so we're only going to give them that in the next year, this year. And I said, wait a minute, we have an expenditure plan that shows you what we do with $19.7 million, even if it is 18.6. And it's, besides, it's all of the program agency contracts, all of the regional council contracts, and all of the other contracts. There's not tons of them, but the PES testing contract, the Key Punch for PCR contract, which is what Phil was talking about, and a few small other ones. We have been trying to renew our Key Punch contract since the middle of 2011. And because the process changes at every turn, it has not been renewed, and therefore we have not spent the money. And so since we haven't spent the money, they took it. So I looked at the expenditures to date the other day and realized we've only spent 40% of our 15.6 million. Now we're halfway through the fiscal year. The fiscal year ends March 31st of 2014. The downside is, as you can tell from you being reimbursed, it is absolutely impossible to get things paid. And so I'm very concerned, honestly, that come March 31st, we're not going to have spent all of the $15.6 million because they will not have actually let us pay you. You know, when you send a voucher into our office, Lisa DeLong processes it. It does not sit anywhere. We have no voucher sitting anywhere. They are inputted and sent. It is done. And it is, so I can't explain it to you. It's a governmental thing I do not understand. But this year, our training fund is at about $7.1 million. There's a probability we will overspend that. The health department has assured me that it will be seamless, that you, the provider, will not know because whatever we overspend will be covered. But no one's put that in writing. So it is, as I said to the state council, if you are running courses, you need to be diligently vouchering for them so that we can get them into the system and that get the money encumbered, because if we don't, we're going to get pinched. And there are changes coming, and you might have noticed from the new funding policies, you know, because we understand that we've not upped the limits much in the last, you know, since 1995. We've changed our, you know, tuition policy. So again, I know that it doesn't affect many of you directly, but it does if you're sending people to training. It does if you're him or you, to a great extent. But keep your eyes on that. What did I miss? Oh, this. I'm going to pass this around. This
It's
is
still on the web, I hate to tell you.
I know. The folks at North Shore LIJ, they have a humongously cool and big ambulance service, sent me this a while back. And I'm going to pass it around. And I looked at it and I thought, isn't that the cutest little cartoon? Until I looked at it for a second longer and I realized it is so demeaning to the EMS community. It was infuriating. So I called our public affairs group director and I sent it to him. And I said, could you do something about this? Because it's a state lottery ad. So he promptly called lottery, and the health department does business with the ad firm that came up with this. And it was intended to be in the New York City market. And it was in the New York City market for about 18 hours, and they took it down. Our PAG guy said that he told the ad agency if they didn't take it down, the health department would no longer do business with them. 18 hours is pretty good, but for 18 hours, it was incredibly demeaning. Cute, but demeaning.
The Article 30 discussions sounds like an opportunity, actually, for depending on how clean the slate is. Where should letters be directed, if you want to have any input to that point?
That is a very good question. I think I would direct them, honestly, to James Clancy, who's the director of the Health Department's Governmental Affairs. I mean, if you send them to me, I will send them there, or you can send them directly. And he's a gift, and he will get them where they need to go.
And is there a time frame for them to wrap this up?
No, the next steps is what I forgot to tell you. The next steps are kind of mysterious. What the governor's office would like to do is put together either a face-to-face meeting or a conference call with REMSCO chairs or a representative from each regional council, and just listen to the council's position. The council, there were two pieces to this. One, the councils were not specifically recognized as stakeholders, as organizations, because you're not, you're actually a statutory body. And most of the people representing organizations were from regional councils. And then one regional council stepped forward and said that they represented all regional councils in the state. And I won't tell you who that is because she didn't represent you. So that's the next step. What could happen next after that, as it's been explained to me, is that there's like 5 options. Option 1 is that it could appear in the budget again, although, again, that's pretty unlikely. Option 2 is that it could be a governor's program bill, and then he would deliver it to the legislature. Option 3 is that it be a 2-house bill, which you're probably most familiar with. Option 4 is that it could be something that is colloquially called departmental bill, meaning that the health department would put it forward to the legislature. Departmental bills are generally intended to correct problems with laws, not rewrite them entirely. So that's probably unlikely. And the last option is that it could just go away totally. So if you I would encourage you, if you want to write to Jim Clancy, or you can send it to me and I'll forward it to him. More input is better, honestly, especially from the EMS community, because I don't want something to happen where it's done in the absence of the EMS. And we're such, as I explained to this poor attorney, it's very complicated, and you know that because you live it. But when you start trying to explain it to an EMS neophyte, it's like what you get is glazing over. And the reason that no one's tackled this before is because it's so complex.
Did they look at other states?
We've looked at other states, but the governor's office has not.
There are other ways of doing this business.
I've looked at Virginia's law. I like Virginia's law, but it also has an ongoing special revenue thing to it that the governor's office is not interested in.
One of the dangers for rural areas, I think, is the economics of it. So if you carve out municipalities where it's feasible and maybe profitable to do inter-facility transports and EMS work, and they're carved out and they're sort of unto themselves, the rural areas are left to figure it out with volley squads that are dying. Jack Stout, a name from the past, when asked, what's up with New York, thought that you need to combine the population of about 1 million people to make it feasible for any fee-for-service contract or commercial service to supply that region. They did it in Acadia, they did it in a few other places. But I think there's a real danger for rural representation to be segregated from the people with the money, which are urban.
Yes, and that's why I don't want you to be quiet. It's important that you're not quiet.
Question regarding the Levofed to the formulary. Is that for the sepsis protocol, or why has that been added to the formulary?
They're talking about replacing dopamine.
For sepsis protocol, or for any?
I
any
believe
hypertension?
everything.
There's been a shortage of the cardiac drugs.
Levofed, yeah.
Levofed and leave them dead. That used to be a
Yeah,
little bit.
yeah, I remember
Be
that.
careful, Isoprel will come back.
Well, it's a circle. It really is.
Rapid kill.
Rapid kill, right?
No, they were, I know at there's talk of replacing taking dopamine out and putting Levofed in. Am I right? Is that what we've heard?
That is what I heard from Dr. Daly.
That's interesting. I know that Levofed now in the sepsis protocol a lot of hospitals are saying, okay, you know, they're gonna put Levis in their sepsis protocol, but some of the smaller hospitals, you know, the rural hospitals are saying, we're not gonna use Levifed because we don't have an ICU, and we're not gonna have a central line on this patient, so we're not gonna use Levifed. So. Okay, thank you very much.
Thank you, Lee.
Okay. Anything else on program update?
No, not really, no.
Other program updates? Do you have anything?
Nothing
Remax?
from Rick. Nope.
Okay. Nothing on program updates, nothing from Rematch. Going to county reports. Delaware, I don't see Steve here. No, we have a couple of classes ongoing, but that's about all I can say right now in Delaware County. At Siegel?
Our classes are ongoing, but other than that, it's business as usual.
Scahary?
Nothing new to report.
Montgomery?
Nothing new for us. I did put a GAVAC training schedule up there. If anybody needs CME time, grab a copy of it.
Yeah, I believe that's on our website also. Unless you've added some more to it.
I think I did put some more on it.
Did, okay, I'll update the website.
Fulton?
Business as usual.
Hamilton?
Doing well.
Okay. Any old business? New business, it's Bonnie Lumen left. There is a position for a member of REMAC, and the only person who really had expressed interest in it since Bonnie Lumen left is Patricia Green.
I believe that's a nurse's slot that's open.
It's a nursing slot that's open. It'd be a nurse from the Northern County. And at this time, I would like to recommend that we appoint Patricia Green for the REMAC. So I'll put that in the form of a motion.
Second that.
Oh, second and by Sid, okay.
Okay. All those in favor?
Aye.
Any opposed or abstain?
I'll abstain.
Okay, thank you. Carrie.
Thank you.
Any other new business? Okay. Motion for adjournment.
We adjourn at 2 p.m. Next meeting will be Thursday, November 21st. REMAC in the morning at 10:30.